Okay, I think we'll go ahead and get started. Looks like most people that are going to be with us are at LinkedIn. First of all, before getting started on today's discussion, Terry and Kurt and I would like to warn you that you have not entirely gotten rid of us yet. There'll be an opportunity if you want to be rid of us. But what we have, we've connected with the people in Plato that are in charge of curriculum and the webinar license and all of that sort of stuff. And they agree that if you are interested, what we could do is to have a program, an occasional kind of program, maybe once a month, twice a month, beginning next month. And it would be probably an hour, maybe even less, in which we could have an opportunity to talk about various events that are occurring. We could get together on Tuesday at 10 o'clock on December 15th and talk about the Electoral College and what they have done. They will be meeting the day before. We could, in the beginning of January, specifically January 6th, we could talk about the January 5th election in Georgia and what happened with the Senate race there. The Senate races, the two that are going to really determine which party is going to be in control of the Senate. And what we could do as well is not just talk about politics and elections, but public policy, the various issues that the Biden-Harris administration are coming up with. We can talk about some state-focused issues. So we'd be happy to have this same kind of format, have a panel of people, have an expert leading the discussion. We've got an opportunity to ask questions and pursue a discussion with them. So to pursue this whole idea, we will be sending out to everyone a survey, probably through SurveyMonkey. And we'll be doing that relatively soon, within the next week, I would say. And with a little preface about what it is, just to remind everybody. And if you want to fill that out, let us know of your interest in whether or not you want to do something like that. We'll ask some questions about topics that you would like to pursue and the like. So you're warned.
You're getting good response, good positive response on that, Dennis, in that session. So
okay, all right, great. That's good to know. So we have Jim Conway is going to be joining us at 10:30, and Terry will introduce him at that point. And the topic is going to be the pandemic and what's been happening, and maybe some questions about what is likely to happen, what are the issues that remain to be resolved here. Have your questions ready, and you can start submitting some of those if you'd like as well. In terms of the election, the update here, as you may know, I think there was an article in this morning's Wisconsin State Journal, front page. Today is the day that Wisconsin certifies its results. It is finishing canvassing, which is the term where each county goes through all of the records, makes sure that the numbers all square, that they match up, that there aren't any questions. The latest results that I heard after the canvassing was that the results really didn't change much by almost a handful of votes. Biden got a little bit more than Trump, so he added in an inconsequential way, but did add to his lead. Then tomorrow is the deadline for the Trump campaign to indicate whether or not it wants to have a recount. And according to the formula used by Wisconsin, if it does want to recount, it has to pay upfront $7.9 million. That cost has been arrived at by each county submitting what it regards as how much it's going to cost them for the space, renting necessary equipment, hiring staff, and doing it all, maintaining safety because of the pandemic. Toby asked a question that she sent early this morning before we all got started, and let me address that. Once the results are certified, and indeed it is official that that Joe Biden and Kamala Harris are the winners in our presidential election here in Wisconsin, then we turn to the electors who will be voting in the Electoral College, and that takes place on a national basis because the certification process that we're finishing today is done at different times by different states. So on December 14th, we have the Electoral College casting the votes. And the question is, so who again are the electors? How does one get to be an elector? And the answer is that is determined by the parties. So in this particular case, the Democratic Party has already determined the slate of electors, 10 people who will be Wisconsin's electors. There's not an opportunity for anybody else to become an elector. And by Wisconsin law, they have to vote for Biden and Harris. There's this term of a faithless elector. We had cases of that 4 years ago. And that depends on state law as to whether or not there's any discretion at all by the people who are on the slate of electors to vote for somebody other than who they were pledged to. And in Wisconsin, the answer is they can't. That if somebody on the Democratic slate says, no, I'd rather vote for an independent candidate or vote for Trump, they can be replaced, and they can also be subject to a fine. So that's how the process moves forward. Let me say a few words about the transition. That is something of concern. At a minimum, one can say that President Trump is not acting in a very classy way. It's clear that he has lost, and most of the lawsuits have been dropped because it is indeed clear. The lawsuit in Wisconsin was dropped. There are a few pending law cases, but in the last few days, most of the lawsuits were just withdrawn by the campaign or surrogates of the campaign. And as Trump kind of continues to sort of deny that he lost the election, and he has told people in his administration not to cooperate, not to provide for a smooth transition, there are several issues that we should be aware of. One is there's just a general issue of legitimacy and somebody like the President of the United States acting as a sore loser and acting as somebody who's not very classy. But that quite aside, there are some real concerns about the pandemic, and particularly, the pandemic, and in two cases, we can save some of this for after 10:30, but there's the issue of how do we stop the big surge that's going on around the country, and of course, Wisconsin's unfortunately one of the leaders here. And the second question has to do with, hey, now that we seem to have not one, but two vaccines that seem to be safe and effective, how do we distribute that? Who gets it first? How do you make the distributions in a way that's fair and that's safe? To do that, you really need to have people who are currently federal employees, who are currently officials in the federal government, sharing their information and their thoughts, what plans they have, if any, with the incoming administration. There are also some national security issues that are being raised, and more people, including some prominent Republicans, are getting concerned about that. On the one hand, we have this kind of strange situation where the president has said, don't give Biden any kind of briefings on intelligence, which is very, very unusual So he's saying, no, don't be giving the briefings, don't be giving that information to the president-elect, although he doesn't really like to call him the president-elect. Ironically, while Biden is not getting briefings, Kamala Harris is. Kamala Harris is getting briefings because she is a member of the Senate Intelligence Committee. So it's kind of, okay, so the vice president-elect is getting briefings, the president is. And I mean, technically, Kamala Harris should not be talking about what she's learning at these briefings with anybody, including Joe Biden. How that's all going to work out, I'm not sure, but kind of a strange situation there. But the other thing that is important here is that, sure, even without cooperation, the Biden-Harris people can start identifying people that they would like to employ in various positions in the government. And inevitably, a lot of these very important positions are going to require a security clearance. And in order to get a security clearance, you've got to have current people in the FBI and some of the other agencies conducting the investigations and certifying that these are people who indeed can be trusted with confidential information about our national security. So that means that you could have a scenario where Terry Shelton is appointed to an important position in the State Department, for example, but because he can't get a security clearance until January 21st, he can't really get ready, he can't do his job, he can't prepare fully for his job. I mean, it's just an awkward situation. And for some people, it's not just awkward, but it does raise risks for our country and puts our country and our armed forces in particular at some risk. The other two situations I would bring to your attention on the lack of cooperation is we've got a guy, he's 30 years old, his name is Johnny McEntee, and he was appointed this past year as the Director of Presidential Personnel Office. And his mission was to basically to dismiss people that were not loyal enough in the minds of the White House and the White House staff. And he has been doing that with a vengeance. And so there's been a lot of attention about, for example, the dismissal of the Secretary of Defense. Well, that's high profile, that has some consequences, but McEntee is really going around dismissing people at lower levels in the federal government too. So that is very disruptive, particularly when you put that together with the fact that people can't get in those jobs, they can't get a security clearance and the like. And the other key position, which is standing in the way of a nice, smooth transition, is the General Services Administration. A woman named Emily Murphy is the head of that organization. That's kind of the real estate organization in the federal government, deals with a lot of the equipment and the like. And there's a law that was passed in 1963, I think it was, that basically said that the General Services Administration, when we've got a new administration, when they've been elected, not after inauguration, but before then, when they've been elected, that they should have access to office space, to machines, to computers. They should have access just generally to the federal government so that they can indeed get started on their jobs. And she has refused to implement that law. She's refused to provide any kind of help here with the Biden administration. And again, you could regard that as an annoyance. Symbolically, it's not really very classy, but it does have some real significant implications too, in terms of allowing for people to get together, to share information. She keeps them from having, for example, access to computers means access to records and access to files. And as I pointed out earlier, just even with the COVID pandemic. That's got some consequences that that are important. Are there questions?
Dennis, so a couple of questions there. One is
Sure.
7.9 million is more than $2 a vote, and that seems high. The thing that I guess I could maybe address that for a second before you get a glass of water, but my understanding is when Stein asked for the recount, that the estimate was 5 million, and it actually ended up costing something like 3.8 million, and so the 1.2 million was returned to the Stein campaign. And so I assume, as you said, the 7.9 is an estimate. We know that, for example, that Milwaukee would have to rent a large space. Dane County said it would have to rent the Monona Terrace so you could spread out people, so that the coronavirus stuff. The Elections Commission itself had said, I think it would cost them $30,000 to just oversee all of this. So to that participant, I think that's what I understand by this. Is that?
Yeah, yeah, that's a real good elaboration, Terry.
Okay. Somebody's wondering whether or not Trump would have won the election without a pandemic.
One can speculate about that. That's it's hard to know. It's one of these what if questions that one can toss around. Clearly, that was a way in which the attack on his governing was lodged. I mean, there was the issue of his style, and there certainly were people who said, well, I don't like the guy. I wouldn't want to sit down and have a beer with him, but he's pursuing an agenda, or he's running the government the way I would like. And if there hadn't been a pandemic, one would guess that you would have to focus on issues like the environmental consequences of his executive orders. You'd have to focus on our standing in the world, and how we are dealing with trade issues, with security issues. So there would have to be a focus on other issues. So it's not like the pandemic was the only issue, but it certainly was. I mean, immigration was a big issue, especially the whole image of little kids put in cages and taken away from their parents. So there were a lot of substantive issues that one would have had to focus on, but the pandemic was low-hanging fruit, if you will.
What about of all those people standing on the stage, could any of the other ones besides Biden have been able to beat him?
Good question. I think that it's clear that there's some people who probably would not have been able to win. People who would have been regarded as too extreme. Clearly, one attack that was made by Trump and the Republicans generally was to say that Trump and Harris were too extreme, that they were captured by the radical left wing, by socialists. And that was a theme that went throughout the campaign. Seems to have had an effect in the Miami area and in Florida, particularly among the Venezuelan and Cuban Americans who were voting. But it didn't really seem to stick with others. And you could make the case, certainly, that it was harder to really, just given Biden's record, Biden's disposition, it was much harder to really make that kind of a case stick on Biden than it would have been on some of the other candidates. Clearly, Bernie Sanders, who calls himself a socialist, whatever that means. I mean, a socialist is sometimes in the eyes of the beholder. It's not a very precise definition.
So one of the participants is really interested in how Trump improved on Black voters. What do you have to say about that?
He did. But we're talking about 1 or 2 percentage points. And this is all based on exit data, which, as I mentioned last time, got to be a little bit careful about the exit data because it doesn't really include all of the absentee voters. Exit data is people coming out of the polls, literally. They're exiting the polls and they're randomly selected to participate in the survey. And usually that's a very reliable source. So Trump clearly was overwhelmed by Biden by most indications. Although it does seem in this polling that that Trump did a little bit better than he did 4 years ago. Just to elaborate on this a little bit, one of the sources of information that I've been looking at lately is not so much the polls, but rather looking at actual voting patterns. And if we take, for example, districts, counties, where the votes were cast and then ask the demographic questions, okay, is this a neighborhood? Is this a community that's primarily African-American? Is it suburban white? Is it Latino, Asian, et cetera? And when you do that, I think you can make a general case that African-Americans and urban and suburban whites really that was a coalition, that was a winning coalition for Joe Biden. So that even if Trump marginally improved from 4 years ago with the African-American vote, he did not with suburban whites, did not with urban whites, and didn't do it certainly enough to lose the election. He did well, as I mentioned, with Latinos in Florida, at least the Cuban Americans and the Venezuelan Americans. But then you take a look at the Latino districts in Arizona and Nevada and California. And again, if you take those communities with a heavy Latino vote, it was really that population that with urban and suburban whites formed a coalition that beat Trump. Now, is this a situation where it's complicated because we have to go, I mean, Florida is different than Arizona. But the other thing is that one telling kind of contest or issue is California with their Proposition 16. Proposition 16 in California was an effort to repeal the ban on affirmative action programs. And you would have thought that that would have been something where minority groups would have been very supportive. Well, Proposition 16 was endorsed by all of the major political figures, endorsed by various advocates like the NAACP for minority groups, but Proposition 16 lost and lost handily, 57 to 43%. And there, the districts that really were responsible for the defeat of Proposition 16 were minority districts, not so much African-American, but Asian and Latino. And Asian and Latino districts, they didn't really want what some people regard as quota systems. Affirmative action is different than quota systems, but sometimes it gets in the minds of many kind of merged together. So the whole issue of ethnicity in the voting patterns is complicated.
Wow. Okay. Well, we've got Jim I think is getting ready to join us. And so
Good.
Dennis, I'm going to save the last question for you on the GSA firing Emily, somebody firing Emily so that we could get this rolling.
Well, it's interesting. I mentioned Johnny McEntee before, the director of personnel for the White House, and he sent out an edict saying anybody who cooperated or anybody who is looking to get another job at this point in time is going to be dismissed. Well, it certainly would. Emily Murphy would be in that category. As of 2 days ago, she started circulating her vita and let it be known that she's looking for another job. So she might get fired by Johnny McEntee. We'll see.
Right. Well, thank you, Dennis. Well,
Sure.
we're being joined now by Jim Conway, and we really appreciate, Jim. I know you moved some things out of the way to do this. We're here with Dennis Dresang and Kurt Sippel and myself with running this one, and we have about 80 participants with us today. And Kurt's going to put your bio up for everybody to see, so we can save some time with that. But just to say that you're the Associate Director of for Health Sciences at the Global Health Institute and a expert in pediatric infectious disease. And we're wondering if you could talk to us a little bit about your experience with pandemics. How did we get here? What do we need to be thinking about? What's the next one? However you'd like to give us some ideas of things to think about. Take it away, Jane.
Thanks, guys. Can you see my screen?
Perfect.
Okay,
We
great.
can.
So what I'm going to try to do in the next, this is like, you know, this whole ordeal has been like drinking from a fire hose, and I'm going to try to give you at least some samplings from the fire hose. One of my medical students said that the other day, and she said, no, it's like they give you a plate of pancakes every day, and the problem is if you don't eat all your pancakes, you still got to eat those pancakes and next pancakes. So that's kind of what this life has become for many of us. So what I'm going to try to do is basically walk you through sort of how this pandemic has unfolded for somebody who's an infectious disease specialist, somebody who works in global health. And, you know, my career has really been focused around vaccines. So I'm going to, you know, hopefully with some time at the end, just share with you kind of where we are and how we're moving forward with trying to develop vaccines. And I'm going to try to, you know, I've been involved in various policy things throughout my career. So I'll sort of sprinkle in sort of how we've been thinking about the policy aspects of this as we've been trying to meet this challenge and sort of share with you the progress that we've made. So I'm going to give you a little bit of history of this pandemic, even though you've all been living through it. I think giving you a little bit of a look for how we've looked at it might help at least clarify some of it. I'm going to talk about how these emerging diseases work and the many pandemics that I've been through and dealt with. I'll talk a little bit about what we've learned about the disease itself, a little bit about the epidemiology, and then talk more about the public health approaches and the COVID-19 vaccine development program. This cartoon here is funny. I actually ran across it the other day because it's actually left over from a talk I gave in 2009 during the H1N1 pandemic, and realizing that the jokes then are just as bad as the jokes now. So making sure that everybody is using the same terminology when we talk about diseases. So an endemic disease is a disease that's normally present and circulates in the population routinely. So things like rhinoviruses that cause common colds and things like that are things we consider endemic diseases. They're here all the time. Epidemics is then when diseases rise to a level above the normal expected level. And so technically every year we have an influenza epidemic, but a pandemic is really when you have an epidemic that simultaneously occurs throughout the world. And that's what we've been living with. And, you know, on the animal side, we actually have this happening as well. And you'll see why this is important in a moment, but we have enzootic diseases, epizootic diseases, and panzootic diseases. All right, so how did this all come together? Well, you know, here's the timeline as we learned about it. So, you know, at New Year's of 2019, we heard about a cluster of atypical pneumonia in Wuhan, which was confirmed by the WHO in early January. And, you know, continued debate about when and how far back this goes has continued. The Wuhan seafood market was closed initially because there was some thought that it was circulating because of some contact with the food items there, but it became pretty quickly apparent that this was actually a human-to-human disease, not a food-to-human disease. And it's really pretty remarkable, the era that we live in, that within a few weeks after this was recognized, the Chinese had actually sequenced the virus, released it to the public within a week for public use by the scientific field, and actually was able to get it published in the New England Journal by January 24th. You know, really unprecedented movement and transparency. Was declared by the WHO to be a public health concern at the end of January. So for those who criticize WHO as being asleep at the wheel, you know, this was much more responsive than we've seen them be in past epidemics. You know, certainly with Ebola, it took them almost a year to declare that this was a public health emergency. And I think they've learned their lesson. So first case outside of China was in mid-January in Thailand. And interestingly, Thailand is one of the countries that has handled this by far the best of most countries in the world. And this was declared a pandemic by mid-March. just 2.5 months after this was first recognized and diagnosed. Again, pretty quick and faster than anything we've ever seen before. And obviously then we all went into safer at home lockdown in mid-March because we needed time to just start to sort this out. I mentioned that nobody's really sure how long this has been around, and there was a study that just dropped yesterday from Italy that actually showed that they have leftover blood samples from lung cancer patients who were being screened for a test trial back in the late summer, and they actually were able to identify that 11% of their population actually had SARS-CoV-2 antibodies dating back all the way back into September, which was interesting because then the Chinese government immediately released a press release last night that said, see, this was actually circulating much further back than Wuhan. And Wuhan was actually the ones that recognized it and made it clear to the world Wuhan was not actually where this started. And who knows, there may be some credence to that. And one of the things to remember is that this is a constant state of existence for those of us that do global infectious disease. There are constantly emerging diseases that are popping up all over the world. Those are the red dots here, as well as blue dots of diseases that have previously been under control that reemerge for all sorts of reasons in different areas of the world, whether it's cholera outbreaks as UN health workers arrive in Haiti, or whether it's the emergence of vancomycin-resistant Staph aureus in other areas as people travel. But this is a constant state of affair. And part of the reason I mentioned the animal role of this is because what we've really started to recognize more and more is that there are abundant viruses that exist in the animal kingdom, primarily in vectors like ticks and mosquitoes, but also in bats and in rodents. And given the volume of these things that are on this planet, it's not surprising that it is a fairly regular process for animals to introduce diseases into some groups of humans. And on occasion, either by their nature or by mutations that occur, these things then suddenly become transmissible from human to human. It's one thing if there's a disease that a bat can transmit to a human as a dead-end host. But as soon as these things become transmissible from human to human, that really is where you get into the potential for epidemics and then pandemics. Add in, animal markets and worldwide travel. And, in many ways, it's more amazing this doesn't happen more often rather than just the 3 to 5 pandemics I've lived with in my career. These are the previous examples of the coronavirus outbreaks that we've had. And I think people should recognize that for many, many decades, we've identified both the influenza class of viruses and the corona class of viruses as being abundant. There's probably 1,000 different strains of coronavirus that circulate in various animals in the world. These are a constant in our society. About somewhere between 5 and 15% of colds every winter are caused by coronaviruses. Similarly, influenza viruses infect pigs, birds, humans, greyhounds, dogs, blue whales, you name it. Almost every species has its own strain of influenza. So we've known for many years that if things emerge, they're going to emerge likely from one of those two pathways. And the commonalities between the first SARS pandemic back in 2002, 2003, and the MERS brief pandemic in 2012, and then the SARS new one, is that these transmitted from bats into some kind of animal and then became human diseases. We still don't have the intermediary for SARS-CoV-2. The pangolin has been surmised, but we're still working out the details of that. Now you add in the emergence of a new disease with how science works nowadays in an internet age where everything is transparent and everything is being done in a bubble. And I ran across this as a really interesting talking point, which goes as follows. So on the top are the confirmed cases and deaths of coronavirus, COVID-19 disease in the world. So here's the beginning of this WHO pandemic. Here's the declaration by WHO. Here's the number of cases as they skyrocketed across the globe over the just first couple of months of this. And here's the number of deaths. And what was really remarkable was that these were the number of publications that came out about this pandemic that matched almost exactly the same slopes. And the interesting part that is really unprecedented in my career is that these pink ones are journal articles that were published in kind of the routine fashion where they're refereed and reviewed by the scientific community. But you can see that almost a third of the things that have been popping out and emerging in the press are things that we call preprints, which are not reviewed and not even necessarily adjudicated for publication, and yet people release them and the media picks them up. And I think part of the reason many of the policy decisions have been so confusing and seem to be pivoting constantly, and in fact why many of us have what I call whiplash, information whiplash, is that a lot of these things never actually hold up to be real, and yet they have the support in the general public and in the media of being scientific. The rule of science is that until something is reproducible and can be replicated over and over again, it's just a theory and a finding. It doesn't become a fact until it's been proven over and over again. And I do think that this has been one of the great problems with this entire year that we've been living through, is just this fire hose of information, about a third of which probably is really not accurate. And so you can certainly see where things that we've talked about for many months, hydroxychloroquine and azithromycin and all these other things, don't hold up once they actually get into the true scientific study process. All right, so what have we learned over this 9 months of studying this disease? Well, what we know obviously is what the disease looks like, and we know that people that experience the disease experience at least one or more of the following in most circumstances: fever, cough and chill, fever and chills, cough, shortness of breath, fatigue, muscle aches, headaches, loss of taste and smell, congestion, runny nose, nausea, vomiting, and diarrhea. Most people. Not all. And so we do know that there are people who sneak through with minimal symptoms or very mild symptoms and can be in fact asymptomatic and able to shed. And that's one of the things that we've discovered, unfortunately, and has made this very difficult to deal with. So what does the typical disease look like? Well, there's an incubation period of between 2 and 14 days after somebody is exposed to somebody else with shedding of the disease. The mean is that somewhere around day 5 or 6, if you get enough virus, you develop you go through the incubation period and then start to develop symptoms. Initially, there's an acute mild phase for most people that's sort of just like a bad cold or a bad influenza. And then, the majority of people then clear that infection. However, there is a group of people that then go into the second phase of the disease that has been called up until recently a cytokine storm, where the immune system basically, as it tries to fight this thing off, essentially overreacts. And so you go down this bad pathway where people really do poorly with a lot of the organ damage and unfortunately death in a large number of people, especially those who have underlying medical conditions. And so this is what this looks like for those of us that are nerds and live in the molecular world and trying to figure out how these things work. And within a few months after this was discovered, people were already coming out with these kinds of illustrations just to explain to each other how these things work. But essentially these viruses latch onto a receptor. This is the infamous ACE receptor, enter the host cell, start to divide and replicate, and then spread throughout the body. And as they do that, they activate different parts of the immune system. This is the lung, and these are the blood vessels within the lung. And as they activate the immune system, they cause more and more swelling and more inflammatory response. And as they irritate the blood vessels, they start to cause then more and more blood clotting. And so a lot of the bad outcomes that you hear about are related to this inflammatory response and this blood clotting issue. And as this keeps progressing in people in these later stages, they get more and more fluid buildup in their lungs, they get more and more clots throughout their entire blood vessel system. And so that's where they start to get kidney disease and central nervous system illness and impact on their heart and all their other organs. So as I mentioned, the majority of people get through this with a mild, bad flu and don't get to a full-blown pneumonia. A substantial number, though, do unfortunately progress to having a full-blown pneumonia with low oxygen levels and evidence on chest X-ray or CAT scan of having had real pneumonia. And then a small but substantial number of people go into this full-blown version of the disease that unfortunately ends up with people in intensive care units on ventilators and over 1,000 Americans dying every day. And I mentioned that the comorbidities are one of the things that we've discovered are most compelling. Age and this kind of long list of underlying medical conditions is what CDC has settled on. But really the way to think about this is that any condition where it impacts how good your heart, lungs, small blood vessels, or immune system are therefore going to be more challenged by having the challenge of this kind of virus and the immune response that goes with it. So certainly those of us that are older have been beating on all these parts of our organs. And, we know about immune senescence as the immune system kind of wears out as people get older. And so there's no question why over 65-year-olds are part of this population. But all of these diseases that are listed here as the primary comorbidities, as their secondary problem, with people with diabetes, people with sickle cell disease, is that they have chronic blood vessel disease that unfortunately makes their blood vessels more susceptible to this inflammatory cascade and clotting problems. Whoops.
Jim, can I interrupt 1 second? Would a vaccine could the risk of vaccine cause some of the things you just pointed out?
If you can hold that thought, I will absolutely get to that.
Okay,
I like the way you think, though. That's exactly why I'm kind of setting the table here. All right, so let's talk first about how we've been treating these things before, and how we're trying to figure out how to treat these things before we talk about what I'm most interested in, was how do we prevent this, get this all shut down, and get ourselves back to something resembling normal. So again, in JAMA, by April 13th, remember, a month after we went into lockdown, scientists had already kind of figured out the pathway of these things, largely because we've been studying coronaviruses for over 20 years and trying to figure these things out. So it wasn't too hard to kind of pivot and look at this particular coronavirus. And so as we look at the life cycle of these things, as these kind of go through uncoating of the thing, they spill out their RNA, they make proteins, they reassemble these things and make new viruses, different ideas came along for different drugs then that could either block processes in this bug reproduction process, or block part of these inflammatory responses to figure out ways to both change what the bug is doing and change what the immune system does. And so we've seen a couple of these hydroxychloroquine and some of these HIV antivirals that people were pretty excited about. Those clearly don't work and don't do anything, but people continue to look at various mechanisms for these things. And this is where remdesivir, the only approved antiviral, works. But as people looked at very specific ways of shutting down certain parts of the immune response and have been unsuccessful, this is then where dexamethasone and other steroids have been used to basically blunt the immune response with a blunt instrument, while we still battle to try to figure out what's the finer surgical approach to this. And this has all been kind of pooled together under FDA, under what's been called the Coronavirus Treatment Acceleration Program. And I think it should be heartening, again, within a couple of months, this program, and FDA is built to do this. I mean, this is not something that was miraculous for this current administration. This is kind of how things are designed. And like I said, I've been through the HIV pandemic, these other coronavirus pandemics, the H1N1 pandemic. We almost dealt with an Ebola pandemic. We've been dealing with a Zika pandemic. Pandemics are not as unusual as people think they are. I think this one's unusual because of the scope and the duration of it. But these things all kind of exist in the background. And that's one of the reasons that the Obama and Biden administration stood up a pandemic response department within their administration, which was unfortunately disbanded by the current administration. But that was part of the reason that that was done under CDC guidance after the review of the 2009 H1N1 pandemic. One of the questions was, why were we slow to respond? And so the response was, we probably need to have a waiting pandemic response program, which was unfortunately a victim of budget cuts during the last administration. But what happens with these things is they gear up very quickly when there's an area of interest. And so this Coronavirus Treatment Acceleration Program, has already, this is just I check this once a week, so this is from 2 days ago, has already reviewed 370 trials submitted to the FDA. There's about 560 drugs that are in various stages of planning. 5 have been approved under emergency use authorization, and currently there is 1 approved treatment, which is remdesivir, approved by the FDA for use in coronavirus. This is the list of what people are looking at. So lots of different antivirals, lots of different cell and gene therapies, lots of different ways of modulating this immune response, lots of different antibody things. You've heard about Regeneron and Eli Lilly's programs and all of these things. That's where these fit in, and then lots of other things, and then combinations of these things. So there is certainly hope and lots of work being done on this treatment side of things. But I think where most of us exist and where most of us would be preferring to be would be, let's prevent this. As Maya Angelou said, do the best you can until you know better. And then when you know better, do better. And so that's really what we've been trying to do. And as I mentioned, as data and information emerges, people change how they address these things. So in the beginning, most respiratory viruses are transmitted by what we call droplet transmission, where somebody coughs or sneezes, like this gentleman from this famous photo from the Boston Museum of Fine Arts called the sneeze. And most of this is person to person, which is why initially the idea was limited to masking for people that had active symptoms as a way of preventing them from spreading what we call mouth rain. And then gradually, as we've started to recognize the role of asymptomatic shedders and the role of potential aerosol, have been when then the recommendations have been modified towards more and more universal masking. So I don't think there's any question that, in the beginning, we treated this like we do most respiratory illnesses and recognize that masks mostly are good to prevent other people from getting contaminated by the person who's sick. We know that for droplet transmission diseases, that if you cough in your hand and then touch things, it's pretty easy to transmit this or touch other people. Keeping your hands away from your face, keeping surfaces clean, staying home when you're sick, and social distancing. This was really the first interventions. But as we learned more and more about this and recognized that this aerosol part of it, that things actually could linger in the room, and in fact that masks actually could diminish the number of molecules and particles that people would inhale, that was where then we had to adjust our recommendations. And I think that from a public health standpoint, I think, all of us in public health and all of us in the government leadership should have been a little more willing to say things in a different way. Basically, it's like your mother told you, if you were wrong, admit you were wrong. And I think from Fauci on down, I think everybody should have said, look, we know we told you that just sick people need to wear masks. We were wrong. We're changing that. It would make more sense for people to routinely mask. And I think that's part of much of what we've struggled with, is that people get anchored to kind of the initial recommendation and keep saying over and over again, wait, but you told us we didn't need to mask. Now you're telling us we do. This is also where it became clear that indoor contact and large group sizes, especially in settings where there was a lot more opportunity to aerosolize. So things like churches and choir practices where people are shouting and singing, or bars where people take off their masks, are in close proximity and are yelling because of loud noises. This is the argument for why those are settings that then need to be managed, and then what we can do about air circulation to try to keep those things from them then being clustered in those settings. I wanted to take a side point here just to make sure everybody understands some of the terminology. People use a lot of these things interchangeably, and I think this has also been one of the problems we deal with. SARS-CoV-2 is the name of the virus that causes the infections that we worry about. And then we label the disease itself that's caused by that virus COVID-19. We talk about people being in isolation after they get diagnosed with the disease. And those isolation initially were 21 days, and then were shortened to 14, and then to at least 10 days. But you're in isolation once you've been diagnosed with the disease. Quarantine means you've been exposed to somebody who had the disease, and you may or may not have been infected. And since the incubation period ranges from between 2 and 14 days, although for most people it's 5 to 6 days, when you're exposed to somebody who is diagnosed with the disease, you are put into quarantine for a 14-day period. If you're sick with the disease, you're isolated for 10 days. And again, these get interchanged all the time. And I think, again, this has been part of the confusion at all levels, both from the government and public health messaging, but also in how the media and the public has understood these things. Next, after we figured out the disease itself and how it's transmitted and what we needed to do, we also had to design more and more testing. And this gets really detailed, and I'm not going to take a lot of time to talk about it. But the most accurate test we have are the nasopharyngeal reverse transcriptase PCR tests that take a lot of technology and a couple of days to get results. More and more what people wanted was rapid point of care testing, like we do with pregnancy tests or strep throat, or rapid antigen tests where you look for pieces of the virus. And these have been coming along gradually, recognizing that the RT-PCRs are by far the most accurate and the most sensitive. Antigen testing, unfortunately, is not quite as sensitive, and it may be useful, but it's not definitive. And so we don't really use these in medical diagnoses. These are really more useful in public health screening. Antibody testing, drawing people's blood, is really only useful to determine if people have had the disease previously and to understand what the immunity looks like. But this is really not a very useful test for diagnosing people with active disease currently. You know, we've gone from having pretty limited testing in Wisconsin. I checked with the state health department yesterday. They're now getting about 40,000 tests per day that are being done in Wisconsin now. Unfortunately, about a third of these are positive. And so the other piece of this is, you know, the ability to then, when you have a positive test, then do contact tracing and figure out who have those people been around to tell them that they need to be in quarantine. Unfortunately, you know, public health is overwhelmed with this and has basically given up on contact tracing, so that the best they're able to do when the outbreak is this widespread is to basically tell anybody who has a positive test, hey, tell everybody you've been around over the last, you know, 3 to 5 days that they need to quarantine. That's how unfortunately pathetic it's become, is that we are so overwhelmed that we can't even do the testing and contact tracing in the way we usually do for outbreaks of disease. All right, so let's look at the results of these daily infections and testing. So this is the United States. This is a site that if you want to follow progress that I follow regularly, IHME, and they monitor all the data from all over the world. And so this is the United States daily infections based on confirmed testing. And you can see this was our first wave. So this was lockdown and our first wave, which overwhelmed the northeastern part of the United States initially. The success of actually people limiting their movements, then opening up of society gradually with these limited masking led to that second wave over the summer. And now this exponential growth. I put this up, this is estimated infections. So obviously, since we didn't have a lot of testing available in the very beginning, we know that we weren't diagnosing everybody. And so the brown dotted line is what we estimate the reality of what we've had in the United States. And this blue line, it's what's happened in Europe. And I think most of you have followed, you know, most of us that have traveled have certainly seen Europe and seen how they are similar but very different. And I think we've seen their approaches to this in a very different way. So when they were initially overwhelmed in Italy and Spain and France, you know, they went into a much more strict lockdown than we did. And they were able to flatten the curve much more readily. And remember, these are rates per 100,000. So this is adjusted for total population. But essentially, they, you know, maintained a much more strict isolation program within their countries. They had much more adept contact tracing. They limited travel into the country much more widely, into the region much more widely. And so they flattened this curve out quite a bit. We kind of were much more loose and, you know, continued to deal with these surges. They obviously, as they started to return to normal in Europe, had an exponential growth. And sorry, this is blocked by the box, but, you know, they're up here today where we are here. But this is the reason you've seen Europe go into a much more strict lockdown and stay at home just over the last 3 to 4 weeks, because their rate of disease per population has really grown out of proportion to even their worst estimates. And so they've really had to lock it down much more strictly. So who has, you know, suffered the most? Well, you know, the number of cases, I think, as everybody's aware, are much more common in the younger population, especially the working population, and, you know, at some level, you know, college populations. But, you know, the majority of cases have been distributed across the sort of, you know, 20 to 60-year-old age group is where most of the illness is. However, those who have borne the brunt of the disease have been in our elder population over the age of 65, especially, you know, in the population over the age of 80. And this is the hospitalization rates, and unfortunately, the death and intensive care rates match along quite closely with that. And within those populations, it's been a disproportionate level of disease in communities of color. So this is data from Wisconsin from a couple of weeks ago that shows that with kind of the size of the bubbles reflecting, you know, this is the percentage of white population and the percentage of cases within the population. You can see that this is cases per 100,000, that Black and communities of color have had far greater rates of hospitalizations and deaths proportionally compared to the other groups. So what has that left us? Well, that has left us leading the world with you know, over 11 million confirmed cases in a country of 330 million. We estimate that at most maybe 10% of the population has had the disease. And you can see that, you know, the largest numbers of cases have been in very populous countries, but also countries that have been a little bit slower to enact wide-scale responses. This contrasts with the countries that have had the best control of these diseases. I mentioned Thailand. Thailand has had only 4,000. They were one of the first countries that had cases, but in a very strict, monarchy that people really do. I teach in Thailand. I should, as a full disclaimer, I teach there every May for a couple of weeks and bring US students to see what a real impressive public health system looks like. I've been doing that for about 15 years as a part of a global health course that I teach. And it was heartening, but not surprising to me to see that a country like Thailand could very quickly move towards universal masking, restriction of movement, and has had only 4,000 cases total with only 60 deaths in the entire country, in a country of 65 million people. South Korea, Taiwan, Australia, New Zealand, Ireland, these are island countries. They've been able to restrict travel. Africa has been really interesting. Most African countries, with the exception of South Africa, have had relatively low rates. And it's unclear whether that's because of the lower age of their general population as a younger population, whether there's certain cultural practices, living in open air conditions rather than closed air conditions where they don't have such limited buildings, a lot more open windows and things. Nobody really understands exactly, but Africa has in many ways been largely spared. It could be a lack of access to testing, although the tests have been more and more available. But it does seem that the universal findings of countries that have done well with this, besides being island countries, have been wide-scale mask acceptance, a centralized government response that's been relatively universal, and the willingness or the ability to restrict movement between highly infected areas and non-infected areas. And we modeled out how this would look. So if I look at mobility of populations, so if 0% is sort of typical mobility of a population, this is the United States data. So this is what mobility looked like when we went into safer at home during March, April, and May. So people limited their mobility by about 55%. People pretty quickly, when we came out of that, returned to the point where when we follow, and we do this by actually following cell phone movement. So looking at your GPS locators on people's phones, and this is widely available public data. Yes, you are being watched. When we got back into kind of routine but limited activity, people's movements were really only restricted about 10 or 15% below normal. Now, as things have gotten worse and worse around the country, and if different states have implemented different restrictions, overall in the United States, even though we all feel like we're suffering and doing nothing close to life as normal, overall, the US social movement has only down about 20% from normal. So for those of you that are really complying and doing your best, unfortunately, about 80% of the country is still out there moving much like they used to on a regular basis. Now, a lot of these are people that have to do it for work to keep their families fed and all these kinds of things. But I think that as much as all of us are suffering, this is only one small piece of the puzzle. How about masking? Well, what we've seen with the US guidelines as they are sort of piecemeal across the country is that currently about 60-something% of the country wears masks on at least a routine basis. The universal mask target would be that if we had wide-scale government policies, we estimate that probably about 95% of people actually would comply with universal masking. And as I think you've seen over and over again, that in every model or in every place that has been done diminishes transmission by about 2 to 3 times. And so this is part of the reason why this has been such a big part of the fight. Well, what has this left us with here in Wisconsin? We are at all of our hospitals at about 120% of our usual capacity for this time of the year, and we're not even into winter yet. Hospitals across the state are at about 90% capacity, meaning that means that there are some hospitals within our state that are full to the brim and are now transferring patients out on a regular basis. And across the state, unfortunately, while we had certain hotspots around urban areas and then up through the Fox Valley initially, where there was a lot of industry and movement, this has now become a statewide problem to the point where just a few weeks ago, the state actually added a new category called critically high. We basically had just very high, high, medium, and low, but essentially everybody was in the very high level. So they created a new category, which already almost the entire state is at the critically high level of amount of disease that we're dealing with. All right, so that's how the public health part of it works, and why these piecemeal policy decisions, unfortunately, have really left us very hampered to minimize this disease. You know, I made the analogy in the media a couple of months ago when we were fighting about the governor's orders for statewide recommendations, and those were overturned by the Supreme Court with the ruling that these would be allowed at the county level. And my analogy was, you know, allowing counties to have different rules was sort of the equivalent of like having a swimming pool where you have a sign that says peeing okay in this part of the pool. You know, essentially what that means is whatever your least common denominator is, that's what the whole pool is going to have. And so having some counties with a mask mandate doesn't really help all that much, because the counties that don't have it, with the amount of commerce and movement around the state that we have, essentially means that the least common denominator behaviors are really what dictate how the state goes. And so that really has been proven over and over again in the United States at both the county level and now even at the state level. And so what you've seen now as a response, while the federal government seems to be incapable of organizing itself at the point of having any kind of universal recommendations, is the idea of creating organized bubbles. You know, one of the most interesting ones to me is the 5 eastern provinces of Canada that have all banded together and essentially have no disease. Now, they actually had to make the tough decision to even ban people from Ontario and Quebec and, you know, the other big provinces. But those 5 small maritime provinces banded together and actually did a very nice job of creating commonalities and basically banning travel. We saw New Jersey, Connecticut, Massachusetts, and New York try to do that early on when they were really under the onslaught. And one of the reasons they were able to get it under control so quickly was because they really did band together and stick together for a while and get it under control so that they could catch up with PPE and all these other things. But unfortunately, in the state we're in right now, you know, I see no end in sight while things are so decentralized and so disorganized. And then lastly, let me just talk about the work we do on vaccines, because this is most of what I spend my time doing. So a couple things just to, a couple of things just to know about. So coronavirus, as I mentioned, are ubiquitous. They're everywhere, they're common. They circulate every winter and spring. About 10 or 15% of colds are caused by these. When we do antibody testing on people kind of arbitrarily, and this is old data, I mean, we've been watching coronavirus for years, but 60% of kids have coronavirus antibodies, about 90% of adults have coronavirus antibodies. The problem being that those antibodies don't necessarily protect very well, and that, you know, the place you need them, which is leaking out into your nose and throat, which is where the viruses land, that only about 8 to 30% of people actually have antibodies detectable in their snot and their mucosa, which is part of the reason why people get reinfected by these things pretty commonly. You know, we know that the earlier versions of SARS and MERS, that those antibodies at least persisted a little bit longer. The disease was much worse. And so if you got it, it seems like it gave a much better immune response. And so there's at least some hope that there may be some residual immunity. What do we know about people who recover from COVID-19? Well, we already know that there are reinfections now being seen, you know, at least a couple dozen that I'm aware of, where people were infected early in the outbreak and have already been reinfected. And we actually can do molecular typing on their virus to prove that it was definitely a new virus, not persistence of the old one. Most of these people have a milder case the second time, but there are a couple cases where people had worse disease. We know that if you're one of these asymptomatic people, that those people lose their antibodies pretty quickly. About 40% of them lose them within 2 or 3 months, as opposed to those that have full-blown symptoms, where those people held on to those antibodies. There was a new study that just came out a couple of days ago that, you know, we can now detect these for people that had full symptoms about 4 to 6 months later. So how do we develop vaccines? Well, the old school way of developing vaccines was either taking toxins from the organism like diphtheria and tetanus, or taking the whole bug like we did with the pneumococcal vaccines or Haemophilus or meningococcus, or taking just pieces of the organisms like we did with, taking the whole organism like we did with varicella chickenpox or shingles. We've gotten more and more advanced over time where we can just take pieces of the bugs like we do for flu vaccines or for whooping cough vaccines. We can actually create new combined live virus vaccines like the rotavirus vaccine. But the idea has always been to move into kind of more high tech, use a surgical knife and come up with just the molecules you need. And so, these kind of high tech, gee whiz, sci-fi versions of things were things like messenger RNA and DNA plasmids. Well, lo and behold, here we are, realizing that all the attempts at developing coronavirus vaccines with these old technologies just didn't work very well. And so we have had to pivot into using things that we had always hoped would come to pass, but have really become, something we had to speed up. How's this work? Well, this is what the virus looks like. And I think as people are well aware, all viruses have all sorts of different parts to them. The one part that is presented to the immune system pretty routinely is this spike glycoprotein, which, knock wood, has fortunately, even though these viruses are all mutating a little bit once in a while, has stayed very stable. And the version of the virus that's circulating worldwide currently continues to have a very consistent spike glycoprotein. The reason that's important, as you know, is that we need to get a new flu vaccine every year because flu viruses change their H proteins and their N proteins, which is why we have H1N1, H5N1. Those unfortunately keep mutating as these things keep spreading from person to person and back and forth into animals. And we have to change the flu vaccine every year. And I think we do have to keep in the back of our mind that eventually these viruses do start to mutate. The SARS-CoV-1 and the MERS version mutated so much that they mutated themselves out of existence, which is how we got those under control, along with good public health measures. But we never know if these things are going to mutate and get worse or actually get elusive for the immune system. And so we do have to be ready to keep changing these vaccines and updating them if these things keep changing. So when we think about vaccines, there's basically two parts to the equation. Is it safe and does it work? And so when you think about does it work, does the immunity it gives last for a long time? Ideally, it would be better than the natural immunity you get from these infections, because as I said, these, immunity from these things does go away. So can it be long lasting, or can we boost it pretty easily? Hopefully, even if you get infected with a mild case of the disease, maybe it prevents you from shedding. And we would like it to activate both parts of the immune system, the part that makes antibodies and the T cells that help us actually fight against viruses. The safety part is really important. We obviously don't want any side effects after you get the injection. We certainly don't want any long-term side effects, which is why even after you get some preliminary data that shows that they protect against the disease, you still want to follow people for at least a few months to make sure there aren't any side effects. And you want to make sure that getting the vaccine and getting an immune response to the vaccine doesn't make the disease worse later when you actually get exposed to the disease. All right, so how do we think about these challenges? Well, the things that make me stay awake at night, the natural immunity appears to be short-lived and doesn't necessarily transfer into mucosal immunity. We don't really know how to measure what good immunity looks like. And so the way we've been testing these things is basically sort of immunizing people and then releasing them into the wild and waiting to see if they get sick with the disease or not. People have argued about whether it's ethical to actually intentionally challenge people with the virus to find these things out. I think the answer has universally been no, because we don't really have a good treatment. Figuring out what the best target antigens are. Right now, we're focused on the spike glycoprotein, but maybe other pieces of the virus will be even better. How do we deal with future mutations? And what's the best way to give these vaccines? Do we give them through the nose? Do we give them orally? Do we inject them? Do they go into the skin? Do they get into a muscle? This enhanced disease thing that we worry about, everybody's heard about this multi-system inflammatory syndrome. And we certainly know even for primary coronavirus infections that there's the late inflammatory stuff. So we've got to make sure that the vaccine doesn't cause that. Again, this durability of immunity, need for boosters. Testing is interesting because we test these things usually in healthy people 18 to 45 years of age, but our focus is on over 65 and people that have other medical problems. And then how do we speed this up and get this done in a fashion that is much more efficient? Most vaccines take about 8 to 10 years to come to the market. And, about 1 in 100 vaccines actually makes it from conception to delivery. So how do we gear this all up? Well, the things that help me sleep at night are that this is really an unprecedented global effort where we've seen really unprecedented collaboration between companies and this widespread sharing of information, including putting stuff out there before it's even ready for publication. Lots of candidate vaccines, lots of novel technologies, lots of money. some national competition, which may be good or bad, lots of novel approaches to the research and development. And then, we've tried to make coronavirus vaccines in the past. We haven't succeeded, but at least people have tried in the last 20 years. And so it wasn't like we were completely starting from scratch. Again, worldwide effort. This is all the places around the world that are involved in either production, testing, development. And there's a lot of vaccines out there. I check once a week. The WHO maintains this draft landscape of candidate vaccines. There's 164 preclinical that aren't even being tested yet that are in labs. This goes up every week. All sorts of different models for vaccines. There's 48 different vaccines that are all in clinical trials around the world. 21 of them are in early phase 1, just looking at what's the right dose and are these safe. 16 are in phase 2, where you're starting to do more and more people to look for side effects. And then phase 3 is where you see 20 or 30,000 people to see, do these actually work to prevent the disease? There's been a couple of vaccines licensed in Russia and China, mostly so they could say they were first. Here's the ones that I think are farthest along. And I've put blue stars next to the ones that the US has invested in. So I think people are aware of Operation Warp Speed, as well as maybe the WHO-led effort called COVAX. COVAX is an effort where all the countries that signed up, about 150, decided to work with WHO to share both their discoveries, but also agree that once they start making vaccine, they'll share them with the world as a whole, including less developed countries, because we can't get this under control unless we shut it down everywhere. As you can imagine, with the current administration, they chose not to be part of that. And so I show this slide because 1, 2, 3, 4, 5, 6, and there's another slide, 7, 8, 9, 10, 11. The 11 vaccines that are all in kind of final phase testing, of those 11, only 5 of them, the ones with the blue stars, are ones that the US actually has skin in the game and has agreements with these countries under our Operation Warp Speed. So we have really taken a somewhat risky gamble by putting all of our eggs into a limited number of baskets, while there are actually a lot of other baskets out there. And so obviously within the scientific community, this is quite controversial. So here's the AstraZeneca Oxford vaccine. Here's the J&J Janssen pharmaceutical. This is the Novavax vaccine. This is a protein subunit. And then here's the 2 that are furthest along, the Moderna RNA vaccine and the Pfizer RNA vaccine. And very exciting, obviously, that they're releasing all this preliminary data, but just reminding people, this is a technology that has never, ever, ever been successfully used for any vaccine on the face of the earth for animals or humans. So both of these vaccines are, coming along quite nicely. They've actually benefited from the fact that, the disease is so widespread and the epidemic is so out of control that the people that have received the vaccine are constantly probably exposed to the disease. So in reality, they're reaching their interim endpoints much quicker than anybody expected, because so many of the people that receive the vaccine are being exposed to the disease. So I guess there's a silver lining at some level. This is the Oxford AstraZeneca vaccine. This is a chimpanzee adenovirus vaccine. They've been trying to use this vaccine model for about 15 years, initially to develop a flu vaccine, then to develop an Ebola vaccine, then to develop a Zika virus vaccine. Never really worked for any of those, but they seem to be hopeful that this one might work for SARS. A lot of virus particles in it compared to most other vaccines we have, which is why it's got pretty impressive side effects. And I think most of you are aware that these trials were shut down for a couple months this fall after a number of cases of neurologic problems. And the reason that, even though the UK allowed the studies to resume pretty quickly, because Oxford is a UK university, the FDA, I think, in a very reassuring approach, shut this down and kept it shut down until Oxford released not only the data from this study, but all of those other previous attempts at using this chimpanzee adenovirus. They wanted to look darn hard at every other attempt with this thing, because we know that adenovirus can cause neurologic problems. We know that SARS-CoV-2 can cause neurologic problems. So there was some plausibility. Maybe this is something we need to know about. And I was actually very reassured that this showed that FDA, despite all the political pressure on them, we're going to take this seriously and treat the safety part as important as anything. And then finally, just to explain the policy decisions for how this Operation Warp Speed thing works. So usually for a vaccine to be developed, you have all this preclinical work. goes into these phase 1 trials, then phase 2 trials. And at each step of this, FDA reviews these things and gives permission. Okay, go ahead, you can go to the next stage. And at the same time, the companies are making a gamble. Is it worthwhile? Is our data good enough that it's actually worth putting money in to start developing manufacturing and commercial delivery processes to be ready to hit the button and go as soon as an FDA licensure happens? What Operation Warp Speed has done, and I think people really need to understand this to be reassured about what we're wanting to do here, is basically has added efficiency into a system that I actually considered for many, many years to be really inefficient. Like, I didn't see why, you know, at this phase here between phase 1 and phase 2, when the companies submitted their data to the FDA, why did the FDA have a whole year to review that and get back to the company? Why couldn't they do that in a couple of weeks? And so what basically has been asked of each of these processes is essentially to speed up the process and to do some of these things at the same time. So as I showed you those previous slides from WHO, you're seeing that some of the companies are doing phase 1 and phase 2 at the same time, or doing phase 2 and phase 3 at the same time in different studies to basically try to speed this up. And what Operation Warp Speed has done is basically pumped about $10 billion into the companies to take some of the risk away so that they can also scale up their production and commercial processing stuff in a way that they actually can have vaccine available as soon as something is known to be available. And so that has included scaling up an allocation and distribution process that we're really right in the midst of doing with both the National Academy of Sciences and the Advisory Committee on Immunization Practice, developing at least proposals for how we ethically allocate these vaccines when they're going to be, at least initially, in relatively short supply. A couple of other things, just because you probably heard them in the media, a lot of kerfuffle about the cold chain needed to maintain these things. I just sort of share with you that, you know, Pfizer's vaccine, which will be the first one we see coming to market over the next couple of months, does require ultra cold, but that ultra cold is, you know, basically the same temperature as we ship ice cream and Omaha steaks. You know, the Moderna vaccine, which will be second, basically, you know, ships and is stored at about the same temperature as we use for other vaccines. And then AstraZeneca and the J&J vaccines are sort of where we sit for flu vaccine. So I don't think this is as big a catastrophe as people think it could be. Now, on a global health scale, this could be a bigger issue because about 3 billion of the 8 to 9 billion people on Earth don't live in an area where those kinds of ultra cold things are available. But some of the other newer vaccines coming along hopefully won't have that cold chain process. And then finally, just thinking through the crude reality of all this, how do we actually think about allocating these vaccines? I think as people are aware, phase 1 of these, you know, will be primarily the high-risk health workers and first responders that are managing COVID patients, largely so we have them available to keep taking care of COVID patients, followed rather quickly by those that are at high risk for having unfortunate outcomes, which is older individuals and people with comorbidities. Phase 2, at least as it's been proposed, will get into people that work in schools and other kind of critical essential workers, people in prisons and people working in long-term care facilities. Only when we get to phase 3 do we get into young adults and eventually children, once there's actually studies being done in children. And finally, you know, we'll get into everybody else who didn't get it through phase 1 and 3. Fortunately, when we poll the public actually does agree that frontline health workers should be first when we poll the public on who do they think should get the highest priority. Interestingly, because everybody wants kids back in school, they actually put kids 0 to 18 second, and then the older individuals a close third. I have bad news for the American public. The kids are going to be not for a while, because until we have good safety data on adults, nobody feels comfortable doing experimental trials in kids. So they're only going to be starting in 12 to 17-year-olds just in the next couple of months. And then finally, the elephant in the room is, of course, vaccine hesitancy and the politicization of all this. And we've seen more and more questions about how willing the public will be to accept these. And in the same breath, we also have to talk about this vaccine nationalism and how, you know, WHO and Gavi have been leading the charge. But as we're all aware, you know, the US walked away from the WHO and no longer has a seat at the table for a lot of these conversations. And so this has become, you know, really something really challenging on the national scale. A couple of weeks ago, a poll was out that only about 50% of Americans even plan to get a vaccine, which, you know, really scares a lot of us, because we probably need at least 80% of of herd immunity to shut down circulation of this disease. I had some heartening news, at least today, that a new Gallup poll came out this morning that says now that all this encouraging data is out from Moderna and Pfizer, it's up to 58% of Americans would accept the vaccine. But this is how politicized this has become, that the American public has actually, in the setting of the life we're all leading, actually stated that essentially they do not trust the scientific process because of how they view FDA and CDC and how political they've become. And the reasons people refuse the vaccines and the political distribution, I think, shouldn't come as any surprise when we look at the groups that would refuse the vaccine versus those that would accept the vaccine. And so, it's been kind of a unfortunate part of this. So in the meantime, this is going to be a while, but I do see some hope for 2021. So, for now, keep pressing on your families. Stay home if you're sick. Hand hygiene, maintain physical distance. Wear a mask, especially when you're in indoor settings, for the protection of yourself and others, and get a flu vaccine if nothing else. So I'll stop there. I know I went a little bit further than I wanted to, but I'm happy to take questions, and I can certainly hang around.
It's fantastic. There were a number of people saying this has just been the best presentation on this that they've ever had, and really, really thank you for how clear and complete it is. So that means you're going to get a shot when it's ready.
Absolutely. I mean, healthcare workers, part of the reason I'm, in many of these advisories is that I want to be there as a voice of reason. And, there are health workers who I think are reluctant, partially because they just misunderstand. I think everybody's, in the health world knows that it takes vaccines a long time. And that's become such a truth that even for the health world, we've had to explain to them that that never was the right way to do things. That was always an inefficient system. And this has really been just adding efficiency that I actually think, is here to stay. I think there's always silver linings in every disaster. And I think that this is one of them, that we're going to add efficiency. The whole concept of Moderna as a company and the mRNA vaccines was to be for pandemic response, was to basically be able to, once you have the organism and have the genetics of the organism, to be able to rapidly be able to then make vaccine without having to grow large stocks of virus and figure out how to purify it. That was the idea. And so this is, kind of the proof being in the pudding. Why don't I tackle some of these Q&As in the chat here?
Yeah. You want to? I'll read them, or if you want to ask.
I can read them and see them. So so Stephanie asks, is there a chance that a vaccine would trigger a cytokine storm? Yeah, that's one of the big concerns. The 2-month data is mostly on side effects from the vaccine. But part of the reason this makes the most sense to go into health workers first is that first, we should be able to understand the concept of informed consent, because these will not be fully reviewed FDA approved vaccines. These will still be under an emergency use authorization, which means the recipient has to consent to it and understand the risks. And I think one of the things, we haven't seen any signals that priming the immune system with the vaccine when somebody comes into contact with the disease leads to enhanced disease with the early data from all of the vaccine trials, but that doesn't mean it's impossible. And one of the things we will watch very, very closely. Sybil asked about the accuracy of the RT-PCR test. So the RT-PCR tests are extraordinarily sensitive at detecting things. And so, if you have active shedding of virus, either in the asymptomatic phase or in the symptomatic phase or in the post-symptomatic phase, they are extraordinarily accurate and very sensitive. The problem being that they're almost too sensitive, and so the specificity suffers a little bit because they still detect fragments of the RNA, in some cases for weeks after people no longer have viable virus. So they're great at detecting things, but they're not great at detecting viable virus. The antigen tests are not quite as sensitive, but they're also not quite as specific. In other words, they actually can detect other coronaviruses. And so they sometimes have a false positive, which is why the current recommendation is anybody who has a positive antigen test should then go get a RT-PCR test to confirm whether the antigen test was a real positive or was a false positive. So antigen tests lack a little bit on sensitivity, but they also lack specificity. What they give us is rapid answers within, in some cases, 15 or 20 minutes. James Steele asks about wastewater testing. Very interesting. So we know that even though these are transmitted to other people through the respiratory route, that they also get excreted in stool. And so what's been tried and has actually turned out to be very helpful is testing wastewater either in communities or, as people have seen at some universities, University of Arizona primarily is the one that's gotten a lot of press, where they're actually testing wastewater in dormitories. And this was especially useful when there was limited tests for humans. They could then target their testing of humans to places where the wastewater was testing positive. And so this was a really novel, I thought it seemed like kind of crazy at first, but it actually has held up pretty well as just a way of monitoring different communities where there's low-level disease to see if there's actually flare-ups. Air circulation inside a building, grocery store, yoga studios, a good thing, or does it spread droplets? Yeah, that's one of the things that's a really interesting question, because there's different versions of quality of air circulation. There's air circulation with filtration, and there's air circulation just blowing things around. So I think people have seen some of the restaurant outbreaks, which were related to air systems where things blow around, as opposed to air circulation where there's actually filtration. And so we know that in more modern buildings, most of them are built with filtration systems that are actually a very good thing. Older buildings tend to have air blower systems for their air handling systems, and those may not be such a good thing. And so, even here at the university, our engineers went around and actually assessed what the air circulation systems were like. And so there are buildings on campus for our in-person activities that are much more usable than there are some that have basically been kind of shut down because they've got such old school air blower systems. Mike gives me a thumbs up. Thank you. I appreciate that. Is there hope of a universal vaccine someday? There is, actually, Lynn. There's also hope for a universal flu vaccine someday. And I still hold out hope that someday, there's certain parts of the flu virus that mutate on a regular basis. There are parts of the flu virus that are actually very stable. The M protein is a very stable part. It doesn't trigger a lot of immunity. And so people have been trying for years to see if we can trick the immune system by developing an immunity to the more stable parts of the virus. And so I do think that there is hope that there could be a more stable universal vaccine that maybe not universal in that it gives you immunity forever, but it might be something more on the order of what we see for like tetanus, where you need one maybe every 10 years or something like that. And there are companies that are working on different models of vaccines, including some companies that are teaming up. And so somebody comes up with like a really cool vaccine idea. Another company has a really cool adjuvant, which is a way we stimulate the immune system much more robustly, that are working together and seeing if they can actually find something that doesn't need to be administered on a regular basis. I think initially, this is kind of going to look like flu for a while. I think we're going to get sort of our first wave of vaccines, and then I wouldn't be surprised if either certain vaccines or certain populations need to get boosters periodically, but time will tell. I think we need to get through phase 1 before we can get to phase 2 and 3. PowerPoint, happy to share a PDF of it with the organizers if that's something you guys do. Michael Stevens asked about, when vaccines become available, will masks and restrictions be lifted? I got to tell you that if I was in charge, I would already be setting the table for people to understand that until, that we're going to have a choice as a society, that if everybody gets the vaccines, once we have enough available, I think it would be much more likely we would be able to more quickly return to some version of normal. If we really have 40% of the population, protesting and refusing the vaccine, and if the vaccines are 90 to 95% effective, to start to limit a disease, for most diseases, we probably need to get over 80% herd immunity. So if I got a 95% vaccine, I need at least 90% of the population to take the vaccine. To get to the herd immunity, I need to be able to shut this down. So we've all got our work cut out for us to convince, only about, on a good year, about 50% of Americans get a flu shot. Last year was about 43%. So unfortunately, until we can do better at somehow incentivizing people and to be willing to get this vaccine, I think masks and restrictions are going to be around for a while unless we get lucky and the virus starts to mutate and become less transmissible. But unfortunately, the mutations it has pulled off over the last 5 months seem to have actually made it more transmissible rather than less transmissible. So, this is two pieces. One is science doing its heavy lifting. 2 is public health, trying to do the best it can to to manage this. But 3, government and public policy people working with public health have got to do a better job of messaging. And, I think threatening people, is not necessarily going to be the answer. So one of the questions people ask about is whether we can ever mandate these vaccines. Mandates, it's one thing for schools where you're putting kids into a closed environment and where the Supreme Court has ruled that the greater good in those kind of settings, does overcome the personal privacy. And schools can certainly exclude kids who refuse to get vaccinated, especially during an outbreak. But it's a lot more difficult for adults. And so I think we do need to do this by cajoling and convincing, and maybe even incentivizing at some point, because that is really one of the things that we're going to need, is everybody to get in this together. Otherwise, we're either going to be living with long and protracted outbreaks probably every winter, or we're going to have to keep doing all this restrictions and all this masking. And I'm tired of it, just like everybody else is. Would I fly right now? So I'm a global health person. I have global health vaccine projects in 12 countries and we're all over the place. I haven't been on an airplane since early March. And there's a lot of reasons around that, including not wanting to unnecessarily expose friends and family, nor wanting to inadvertently pick something up and introduce it. If I did fly, I would be a person who would insist that we do the right thing, which is then quarantine upon arrival and quarantine upon return. I do think planes and the air filtration systems they have are actually quite good. And with universal masking on planes and good hand hygiene and other activities, especially in airlines that are allowing some distancing between people with blocking of seats, if I absolutely had to fly, I certainly would if there was a family emergency, but I don't think it would be something that would be imperative. Should we still be wiping down groceries? I think that is a minimal risk in most circumstances. And so my family gave up on that probably in May. So I think that the introduction of things on what we call fomites, delivery systems, are really minimal. This is still primarily a person-to-person droplet disease where almost everybody that gets sick with it gets sick by being in close contact with another individual for a prolonged period of time, which prolonged is more than 15 minutes, and does not practice good hygiene. Either the person that they're exposed to may not be wearing a mask or does not wash their hands or cover their cough. So I think if we just maintain the 4 big things: masking, hand hygiene, staying home if you're sick, and keeping our distance from one another, that is really very effective and has been proven over and over again. I think in the interest of time, I'll stop there.
Okay, there are 2 if you want to ask in the chat. One is, can you talk about what UW testing is going on? And the other is psychiatric care, people who've been depressed or the repercussions of that. Those are the last 2 in your chat.
Yeah, UW on campus, we've been testing all of the on-campus students. Right, everybody can get a test if they have any symptoms. And then all the on-campus students get tested routinely. We have active isolation of anybody who tests positive, as well as pretty good contact tracing. So the people that are exposed to anybody who's diagnosed then go into quarantine, and there are quarantine locations. I have to tell you that, as much as the media made a lot out of students returning to school, and we did have kind of a mini outbreak on campus in September, when the chancellor put all the students in timeout for 2 weeks in their own lockdown, I think it both settled things down quite well as sent a clear message that she was serious about this and that we were serious. And in fact, if they didn't behave, we would essentially close down the university. And I got to tell you, I am very comfortable on campus. Students are universally wearing masks, both indoors and outdoors. And we will be going to even more aggressive testing in the next semester. I understand that we now have sufficient testing that there's going to be testing for all students twice a week. We also have readily available open testing for the off-campus students as well as faculty and staff. And so we've been very comfortable on campus, that things have been very well done. The other UW system campuses, have had a little bit more challenges. We've been fortunate because we have a lot of diagnostic and scientific laboratory space and people on campus. But, you know, each of the campuses has had their own approach to this, and partnering with their local public health groups, you know, have really done a pretty nice job of managing these things. And, you know, I do think that these things are overall quite manageable. You know, I think we all want schools in general to be back in session, especially for younger kids. You know, I think one of the policy things that's been really interesting to me is that Europe has prioritized elementary schools and has been willing to close bars and restaurants to make that happen most recently. And, you know, we've unfortunately in our country taken a different route where people have been very insistent on having the capacity to have at least restaurants open, whereas schools have unfortunately been the ones then forced to manage in a virtual existence, even for young kids, or at least in hybrid situations. And I think it does speak to kind of how people prioritize the economy and the economic issues over childhood education and childhood neurodevelopment. I'm not saying one is right or wrong, because I think people certainly see an economic devastation for Europe, which was already pretty brittle, especially in Italy and Spain and some of those other countries with large unemployed young adult workforces. But it's just interesting how different societies prioritize these things. What was the other one?
Whether or not it's out of your bailiwick, perhaps, psychiatric care involving all of this.
Oh, yeah. I mean, I think both, you know, there's two pieces to that. You know, one is there are clear neurologic issues in people who recover from COVID-19 infection. And so we're seeing, you know, pretty widespread and persistent, you know, fatigue and mental fogginess, even in young adults who survive these things. I think that there's no question that this is a multi-system, multi-organ disease that does significantly impact every organ in the body, including the neurologic system. And so that's one whole piece of it. On top of that, then, you know, all of us, and especially kids, you know, who are in social isolation and not having those regular social interactions, that's a whole other piece of it that is really devastating. And I think this has really kind of ripped a pretty nasty Band-Aid off what a lot of us already knew about, which is that mental health services in this country are incredibly woefully under-recognized, under-supported, and underfunded. And this has really unmasked that important component. And so I think that's going to be a whole other really unfortunate side effect that we're going to deal with over the next 5 to 10 years is, you know, depending on how long this goes on, you know, an entire group of people that just don't have that joy and feeling that value and importance of social interactions. And so all of those reasons are reasons that we need a unified, consistent, understandable public health message and approach to this in ways that people can comply with, that get us back to something resembling more normal for all of us on a regular basis. Because, you know, this is without a doubt, as much as I've lived with other pandemics throughout my career, this is like nothing anybody else has ever lived through. And the only thing that comes even close is the flu pandemic of 1917, which we only have, you know, scant records to really understand the deep devastation of that. But this is unprecedented, and it will continue to be so until we can figure out a way to get all these things pulled together.
Jim, thank you so much for taking the time. Such an excellent thing. And I'm going to let Dennis do a benediction maybe for the whole class. I don't know, Dennis, but Jim, if you want to hang around for the benediction, but thank you so much. It's been excellent.
My pleasure.
Dennis?
Yeah, well, the benediction is really focused on Jim, and a real heartfelt thank you. We really appreciate it. And as people have already expressed, very clear, very useful, very thorough, and good news for everybody. And that is that this session, like our others, has been recorded. And so in a day or two, if you go to the Plato website under past lectures, you can get a nice review. And it's something that I think is worth sharing, that other people who didn't have a chance to participate this morning can get this information. So Jim, thank you very much. And everyone have a great day. Great
Thank you.
week.
Thanks a lot, everybody.
Happy Thanksgiving.
Happy Thanksgiving. Stay safe.
All right. Bye now.